Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome back to the Deep Dive. Today we are taking on something pretty remarkable in modern medicine, autologous QR T-cell therapy. It's this highly personalized, very high-stakes kind of therapy. You know, they often call it a living drug. It's really changed the game for a lot of blood cancers.
It really has. A paradigm shift, no question.
But its success, it absolutely hinges on this incredibly complex process called the vein-to-vein journey, or V2-ideal. That's the whole sequence, right? From collecting the patient's T-cells, sending them off, engineering them, getting them back, and infusing them. So our mission today is really to unpack all the steps, the logistics, the science, everything involved in this V2V2 pathway. Because honestly, it's basically a race, a multi-week race against some very aggressive diseases.
Exactly. And what's critical to understand is that this V2VT timeline, it's not just about scheduling. It's a direct factor in how well the therapy actually works. It demands just incredible coordination. You need apheresis teams, manufacturing labs, oncologists, ICU specialists, everyone perfectly synchronized. And delays, well, we have data showing that delays in this journey are linked to worse outcomes for patients. Speed and precision are everything.
Okay, so let's start right down at the molecule level. The blueprint for this living drug. It all starts with taking a patient's own T lymphocytes and genetically engineering them. They're engineered to express this synthetic receptor, the chimeric antigen receptor, the CRR.
And that CRR is the key innovation. It gives the T-cell this amazing ability for MHC-independent recognition, major histocompatibility complex. Normally, you see T-cells need that MHC complex on the tumor cell surface to present the cancer antigen. It's like needing the right key and the right lock.
Right, but tumors are clever. They learn to hide, basically, by getting rid of that MHC presentation system.
Exactly. Downregulating MHC expression is a classic immune evasion tactic. But there are a T-cell. It doesn't need it. The CRR receptor binds directly to the target antigen on the tumor cell surface, like CD19 on lymphoma or BCMA on myeloma. It completely bypasses the MHC requirement. Think of it like a heat-seeking missile that doesn't need the target to be perfectly illuminated.
And the power of these engineered cells, it really comes down to the internal design, right? Especially the ones currently approved, these second-generation CRs.
Yeah.
Let's break down that structure.
Okay. So outside the cell, you have the targeting part. That's usually a single-chain variable fragment, an scFv, derived from an antibody. That bit determines what antigen it goes after. Then there's a part anchoring it in the T-cell membrane. But the real engine, that's inside the cell, the signaling domains. All current products have the main go signal, the primary activation domain, which is CD3 zeta. That tells the T-cell to kill. But the second-generation part means they also have one extra signal, a co-stimulatory domain, and the main choices are either CD28 or 41BB, which is also called CD137.
And that choice, CD28 versus 41BB, that's a really crucial design decision.
Yeah.
It affects how the final T-cell product behaves in the patient, doesn't it?
Oh, absolutely. That second signal is non-negotiable. You need co-stimulation for the T-cell to really get activated properly, to proliferate massively inside the patient, produce the right cytokines, and, critically, to stick around long-term. Persistence. Without that co-stimulation, if you just had the CD3 zeta signal, the T-cells would activate briefly, then become anergic, basically shut down, useless.
So let's compare them then.
Yeah.
CD28 versus 41BB. What's the functional difference for the patient receiving those cells?
Yeah, that's a really important clinical point. So CARs using CD28, like Axicell, Yescarta and Tecartus, they tend to cause a really rapid, very strong initial expansion of the T cells. This often leads to a faster clinical response, which is great, but sometimes also a faster onset of toxicity. The downside is, this sort of explosive initial growth might lead to them burning out faster, potentially shorter persistence over months or years. On the other hand, seers with 4-1BB, like Tisa-cell Kymriah and Lisocell Breyanzi, they usually expand a bit more slowly initially. But the resulting T cells often have a phenotype that looks more like memory cells, less differentiated. And this seems to translate into longer persistence in the body. That's obviously really important for preventing relapse and maybe achieving those long-term cures.
So it's a trade-off then. Speed versus endurance, kind of.
That's a good way to put it, a fundamental design trade-off.
Okay, now let's layer this onto the logistics. The vein-to-vein timeline. You mentioned the whole journey, start to finish, can be around 3 months. That's a huge undertaking.
It is. And the V2VT time itself, strictly defined, that's from the day of apheresis, the collection, to the day of infusion, even that specific window is long. You've got patient evaluation, getting approvals, that can be quick, maybe 5 days, but sometimes it drags out for over 4 weeks. Apheresis itself is quick, a day or two. But then the manufacturing. That's the big one. 2 to 6 weeks typically. That's the main bottleneck. After that, you need a few days, maybe 3 to 5, for lymphodepleting chemo, the LDC. Then the infusion itself is fast, less than an hour. And then mandatory close monitoring for at least 30 days.
Wow, that manufacturing gap, 2 to 6 weeks. That sounds terrifying for someone with aggressive cancer. The cells are being made, but the disease is still growing.
Exactly. That's why the V2VDT duration isn't just a logistical number. It's a critical clinical variable.
And there's data to back that up.
Oh, yes. Real-world data, especially for aggressive large B-cell lymphoma, LBCL, studies looking at axi-cell showed pretty clearly that patients whose V2V time stretched out to 40 days or more, they had significantly lower rates of achieving a complete response, and even worse overall survival compared to patients with a shorter V2V team. That 40-day point really seems like a critical threshold.
Okay, so that intense time pressure explains why the specific turnaround times for the different commercial products are such a big deal. They're not all the same.
Yeah, they're not. For LBCL, for instance, Yescarta, which is axi-cell, often has the shortest reported median V2V, somewhere around 27 to 31 days in studies. Breyanzi, Lisocell, tends to be intermediate, maybe around 36 days median. And Kymriah, Tisa-cell, historically has had the longest median V2V, sometimes up around 45, even 48 days.
What causes that variation? Is it just the tech, the biology, or is it also about the company's logistics?
It's definitely a mix. The underlying technology, the vector type, the expansion methods, that plays a part. Different processes take different amounts of time, but the logistics are massive. Things like the size and location of the manufacturing plants, where the cells are frozen and stored, how quickly the quality control tests get done and released, even just the shipping routes. It all adds up. So for clinicians treating a patient whose lymphoma is really taking off, sometimes choosing the product with the most reliable, shortest V2VT becomes a major deciding factor.
Right, so the journey actually starts way before manufacturing. It starts with picking the right patient. And you said this isn't just a quick check, it's a really rigorous process, multidisciplinary.
Absolutely, it's a whole team effort. Oncology, cardiology, nephrology, sometimes pulmonary, social work, transplant specialists, they all weigh in. First, the basics. Clinical criteria. Does the patient have the right type of cancer? An FDA-approved indication like relapsed or refractory LBCL after 2 lines of therapy or myeloma after so many lines. And critically, do their cancer cells still express the target? CD19 for many lymphomas, BCMA for myeloma, you have to confirm that. If the target's gone, the therapy won't work. Pointless.
And beyond the cancer itself, the patient has to be, strong enough to withstand the treatment and its side effects, right?
Yeah.
You mentioned induced organ issues.
That's the physiological criteria. Huge factor. Generally, patients need a good performance status. ECOG 0 or 1 is typical. That means they're up and about, maybe restricted from heavy physical work, but not bedridden, because the treatment will cause side effects, potentially severe ones like cytokine release syndrome, CRS. So significant pre-existing problems like poorly controlled heart failure, severe kidney disease, bad lung function, those can rule a patient out. They might not tolerate the therapy.
And then there are these intense logistical requirements, a big commitment for the patient and their family.
Yeah, these are non-negotiable safety rules. The patient absolutely must have a dedicated caregiver, someone available 24/7, especially for that first month after infusion when toxicities are most likely. And they have to live close to the treatment center, usually within a 1 or maybe 2-hour drive. That's for at least 4 weeks post-infusion. If they develop severe CRS or neurotoxicity, they need expert care immediately. Minutes can matter.
Okay, now let's talk about the raw material itself. The T cells. You said the collected cells are like a biopsy of the patient's immune system health. How does all the prior cancer treatment affect those T cells?
Prior therapy is a huge issue for T cell quality. Patients who've had lots of chemotherapy, especially certain types, we call them lymphotoxic agents, things like fludarabine or bendamustine, their T cells are often just not in great shape by the time they get to CRT. The collection might yield lower numbers of T cells, fewer viable cells, and the cells themselves can have what we call an exhausted phenotype.
Exhausted phenotype. What does that mean functionally?
It means the T cells might express high levels of checkpoint inhibitors like PD-1 or LAG3. They've been fighting the cancer, maybe battered by chemo. They're just tired. Less able to activate, proliferate, and persist after they're engineered and reinfused. Poor quality starting material like that. It increases the risk the manufacturing will just fail, the lab can't grow enough cells, and even if they manage to make a dose, those exhausted cells often don't expand well in vivo, leading to worse clinical outcomes.
So the sire design could be perfect, but if the starting cells are weak.
Exactly. It really underscores the potential benefit of using sire T cells earlier in the treatment course, before the immune system gets too beaten down by multiple lines of chemo.
Makes sense. So assuming the patient is eligible, the next step is the collection itself, leukapheresis.
Right. It's basically a specialized blood draw. Takes about 4 to 6 hours, usually outpatient. The machine draws blood, spins it down, separates out the layer containing the white blood cells, including the T cells we need, and returns the rest of the blood components to the patient. The main requirement is good blood flow. You need good veins, usually 2 large bore IVs. If the patient's veins aren't great, which is common after lots of chemo, they might need a temporary central line, like a dialysis catheter, put in just for the collection.
Okay. And during that 4-6 hour procedure, what's the main side effect they need to watch out for?
The big one is hypocalcemia, low calcium. It's caused by the citrate anticoagulant used in the apheresis machine circuit. When that citrate goes back into the patient, it binds up calcium in the blood. Symptoms can be mild, like tingling around the mouth or in the fingers and toes, sometimes muscle cramps. Rarely it can get more severe, like muscle spasms, tetany. So the apheresis team watches closely and usually gives calcium supplements, either pills or IV, during the procedure to prevent this.
Before the collection even happens, though, there's this crucial washout period. Patients have to stop certain drugs. Why is stopping potentially life-sustaining treatment necessary right before collecting the T cells?
It's all about T cell health. We need to collect the T cells when they are as functional and numerous as possible. If the patient still has chemo or high-dose steroids circulating in their system, those drugs can suppress the T cell numbers, sure, but worse, they can directly impair the ability of the collected T cells to be activated and genetically modified in the lab. You could end up collecting cells that look okay initially but just won't grow or take up the CR gene. It could doom the whole process before it even starts.
So what are the typical washout times? How long do they need to be off these drugs?
It depends on the drug. For something like high-dose corticosteroids, say dexamethasone or prednisone, they generally need to be stopped at least 72 hours before apheresis. For standard chemotherapy agents like cyclophosphamide, it's usually a longer period, maybe 2 weeks or more. And then there are the really potent lymphotoxic drugs like bendamustine or fludarabine. These can hammer T cell function for a long time. Ideally, clinicians try to avoid these for at least 12 weeks if possible before a planned apheresis.
12 weeks? Wow. But for someone with aggressive lymphoma or myeloma, stopping treatment for 3 months, that seems impossible. They could progress too quickly.
That is the fundamental dilemma, the clinical tightrope walk. You need the washout for good T cells, but you can't let the patient's cancer run rampant. This is where bridging therapy comes in. Between stopping the problematic drug and the apheresis, or between apheresis and the final CAR-T infusion, clinicians often have to use some kind of therapy. But it has to be carefully chosen. Usually something less toxic to T cells, maybe low-dose chemo, a targeted agent, sometimes radiation to a specific problem area. The goal isn't cure, it's just control. Keep the disease stable enough, keep the patient well enough to make it to CAR-T infusion without compromising the T cell collection.
Okay, so the cells are collected, frozen often with DMSO as a cryoprotectant, and shipped off to a specialized manufacturing facility. This is where the real bioengineering happens, the ex vivo part. What's the first step when they arrive?
First, they usually need to isolate or enrich the T cells, the CD3 positive cells, from the rest of the collected mononuclear cells, often done using magnetic beads. Then, critically, these T cells have to be activated. You can't efficiently get the CAR gene into resting T cells. Activation is typically done using beads coated with antibodies against CD3 and CD28. This mimics the natural signals a T cell receives when it encounters its target antigen. It basically wakes them up and tells them to get ready to divide.
Once they're activated, then comes the gene delivery, using those viral vectors we talked about.
Exactly. Transduction. That's where the CRR gene construct is inserted into the T cell's DNA. The two main types of vectors used commercially are gamma retroviral vectors and lentiviral vectors.
Remind us of the difference again. You mentioned Yescarta and Tecartus use retroviral.
Right. Gamma retroviruses primarily integrate their genetic material only into cells that are actively dividing at the time of transduction.
Okay. And Kymriah and Breyanzi use lentiviral vectors.
Correct. Lentiviruses have a key advantage. They can transduce both dividing and non-dividing cells. This is potentially really important because it means they might be better at getting the CRR gene into those desirable, long-lived, quiescent T-cell populations, like memory stem cells. These are the cells thought to be crucial for maintaining that long-term immune surveillance and durable responses.
And you mentioned a safety aspect, too, regarding where the gene gets inserted.
Yes. There's always a theoretical risk, however small, with any integrating vector that it could insert itself into the wrong place in the genome. Maybe disrupting a tumor suppressor gene, potentially leading to a secondary cancer down the road. It's called insertional mutagenesis. While the risk is considered very low with modern vectors, lentiviruses are generally thought to have a slightly more random and therefore perhaps safer integration pattern compared to some older gamma retroviral vectors.
Okay, so the gene is in. Now you have a small number of engineered T cells.
Yeah.
The next step is expanding them into the billions needed for a therapeutic dose. How's that done?
Expansion. This usually takes about 7 to 14 days. The cells are cultured in nutrient-rich media, supplemented with growth-promoting cytokines. IL-2, IL-7, IL-15 are commonly used. They tell the T cells to proliferate, to make copies of themselves. And the technology for doing this has evolved too. It used to be done in flasks, more manual. Now it's largely moved to automated closed-system bioreactors, things like wave bags or stirred tank systems.
Does the type of bioreactor make a difference to the final product?
Well, the automation helps ensure consistency and reduce the risk of contamination, which is huge. Stirred tank systems, in particular, can support much higher cell densities. This might allow manufacturers to grow the required number of cells faster, potentially shortening the overall manufacturing time.
And shortening that time relates back to the quality, right? These critical quality attributes, or CQAs. The idea that how long you grow them impacts the type of T cells you end up with.
Absolutely critical. The composition of the final product, specifically the ratio of different T-cell subtypes, is a major CQA. We know that products containing a higher percentage of less differentiated T-cells, think naive T-cells, TN, or central memory T-cells, TCM, tend to expand better in vivo after infusion and persist much longer. They have greater potential for long-term efficacy. If you culture the cells for too long ex vivo, you risk pushing them towards a more differentiated effector phenotype or even an exhausted state. These cells might be potent killers initially, but they don't stick around as long. So the manufacturing process is constantly balancing getting enough cells versus maintaining that desirable, less differentiated phenotype.
Fascinating. So before this precious batch of cells can be frozen again and shipped back, it has to pass a battery of quality control tests. Safety, purity, identity, potency. What are they checking for?
It's a comprehensive checklist. Safety is paramount. Tests for sterility, no bacterial or fungal contamination, and endotoxins. Purity means checking what percentage of the cells actually express the CIR on their surface, usually done by flow cytometry. Identity confirms these are indeed the correct patient's cells. And then there's potency. This is a functional test. They need to show in vitro that these engineered CRT cells can actually do their job, recognize and kill target cells expressing the specific antigen.
And thinking back to the gene insertion, there's that safety check too.
Yes, the vector copy number, or VCN. They measure, on average, how many copies of the viral vector DNA have integrated into each T-cell genome. This has to fall within a specific, validated range. Too few copies, the product might not be effective. Too many copies could theoretically increase that risk of insertional mutagenesis we talked about. Only when the product meets all these release specifications is it finally signed off, cryopreserved, and sent back to the treatment center.
Okay, the engineered cells are on their way back. Billions of them, frozen. While that's happening, the patient is being prepared. We touched on bridging therapy earlier for aggressive disease. Can you recap its role?
Right, bridging therapy, it's used in that gap maybe between apheresis and LDC for patients whose cancer is growing quickly. It's highly personalized, maybe some low-dose chemo, a targeted drug, maybe radiation. The goal isn't to cure, it's purely to keep the disease under control, maintain the patient's performance status, so they're still eligible and fit enough when the sour T cells finally arrive. It's buying time, essentially.
Got it. Then, right before the infusion, comes the lymphodepleting chemotherapy, LDC. Seems counterintuitive, giving chemo just before the immunotherapy. You stressed it's not really for the cancer.
That's crucial to understand. LVC is mandatory, given typically in the few days just before infusion. Its purpose is not primarily anti-cancer, although it might kill some tumor cells. Its main job is to prepare the patient's body, the in vivo environment, for the incoming CRT cells. It optimizes conditions for them to engraft, expand, and persist.
Okay, what are the main ways it does that? You mentioned 3 mechanisms.
Yeah, 3 key things. First, it causes lymphodepletion. It wipes out many of the patient's existing lymphocytes. This literally creates physical space or niches for the infused hard T cells to occupy and expand into. Second, and this is really important, it gets rid of what we call cytokine sinks. The patient's own immune cells normally consume essential survival cytokines like interleukin-7 and interleukin-15. By removing these competing cells, LDC increases the availability of IL-7 and IL-15 for the CAR T cells, fueling their survival and massive proliferation.
Okay, so clears that competition for resources. Makes sense. What's the third one?
Third, it reduces the numbers of immunosuppressive cells in the patient, particularly regulatory T cells or TREGs, and maybe myeloid-derived suppressor cells. These cells actively put the brakes on T cell responses, so LDC helps release those brakes, and the clinical data is overwhelming on this. Patients who don't get LDC or get inadequate LDC have much poorer CAR T cell expansion and significantly worse treatment outcomes. It's absolutely essential.
And the standard regimen is usually fludarabine and cyclophosphamide, Flucy, given over a few days.
Yes, Flucy is the most common backbone. Studies showed it's significantly better than using cyclophosphamide alone. For many products like Yescarta or Tecartus, it's often given on days like -5, -4, and -3 before the CRT infusion on day 0. That timing maximizes the beneficial effects right when the cells go in.
But you also mentioned LDC can be customized, maybe less intense regimens like bendamustine for frailer patients. Isn't there a risk that dialing back the LDC might compromise the CRT efficacy?
That's the trade-off exactly. Bendamustine is sometimes used, for example, with certain Kymriah indications, particularly in patients who might not tolerate the myelosuppression of Flucy. It's generally less harsh. But yes, there is evidence suggesting that less intensive LDC regimens might lead to less robust CRT cell expansion and potentially lower efficacy compared to standard Flucy. It's a clinical judgment call, trying to balance the need for effective lymphodepletion with the patient's ability to tolerate the chemo. You aim for the best possible outcome the patient can safely handle.
Okay, day 0 arrives. The CRT cells are thawed and ready. The infusion itself is quick, but sounds like it needs meticulous care. What happens just before?
First, absolute certainty about identity, usually a 2-person check. Verifying the specific cell product details match the specific patient identifiers on their wristband, the chart, everything. No room for error there. Pre-medications are simple, typically just acetaminophen and an antihistamine like diphenhydramine. The key thing here is what not to give. Prophylactic systemic corticosteroids are strongly discouraged. They could blunt the initial activation and expansion of the CAR T cells, potentially hindering the treatment's effectiveness right from the start.
And the thawing itself. You said it's a race against time?
It really is. The frozen bag of cells must be thawed quickly right at the bedside, usually in a 37°C water bath or using a validated thawing device. As soon as it's thawed, the infusion needs to start almost immediately, typically within 30 minutes. That's because the cryoprotectant, DMSO, which keeps the cells safe when frozen, is actually toxic to them at room temperature. Letting the thawed cells sit around will kill them, reducing the effective dose.
And one absolute do not regarding the IV setup.
Critically important. Never, ever use a leukocyte depleting filter in the infusion line. Those filters are designed to remove white blood cells. You'd literally filter out the therapy you're trying to give.
Makes sense. So the infusion happens maybe over 30 minutes or so. What do they watch for immediately after?
Mostly transient side effects from the DMSO. Patients often report a distinct garlic-like taste or smell. Some might get mild nausea, maybe a brief fever spike or chills. Usually Mycurine passes quickly. Then the real waiting and watching begins.
Right, the cells are in. Now the focus shifts entirely to monitoring for and managing the side effects. That first 30 days is the really critical window for acute toxicities, hence the need to stay close to the center.
Exactly. The CR-CAR T cells are now encountering the tumor, activating, proliferating massively, doing their job. But that very process unleashes a huge inflammatory response systemically.
Yeah.
So monitoring is intense, frequent vital signs, often every 4 hours initially, daily blood tests looking at blood counts, organ function, and specific inflammatory markers like C-reactive protein, CRP, and ferritin, and regular formal neurological checks are absolutely mandatory.
Okay, let's break down the big two toxicities. First, cytokine release syndrome, CRS. What's happening biologically during this cytokine storm?
CRS kicks off when the SIRE T cells engage their target antigen on the tumor cells and start multiplying rapidly. This activation causes them to release inflammatory signaling molecules, cytokines, particularly things like interferon gamma and TNF-alpha. But these initial cytokines then act on other immune cells nearby, especially monocytes and macrophages. They activate these bystander cells, and these activated monocytes and macrophages then pump out massive amounts of other cytokines, predominantly interleukin-6, IL-6, and also interleukin-1, IL-1. It's this flood of secondary cytokines, especially IL-6, that drives the systemic symptoms of CRS fever, leaky blood vessels, low blood pressure, potentially leading to organ damage if unchecked.
Fever is the classic first sign, right? Often starting within just 2-3 days for the CD19 CCARs. How is CRS graded, and how does the management change with severity?
Yes, fever, AO 38 degrees C or 100.4 degrees F is the cardinal sign. We use standardized grading, typically the ASTCT consensus criteria. Grade 1 is basically just fever, maybe some mild fatigue or headache. Managed with supportive care fluids, fever reducers like acetaminophen, keep a close eye. Grade 2 is the threshold where things get more serious. The patient might need supplemental oxygen due to hypoxia or perhaps low doses of vasopressors for low blood pressure. At grade 2, standard practice is to intervene with targeted therapy, tocilizumab. That's a monoclonal antibody that blocks the receptor for IL-6, hitting the key driver cytokine. If it progresses to grade 3 or 4 severe life-threatening CRS with high oxygen needs, maybe needing mechanical ventilation or requiring multiple high-dose vasopressors, then it's an ICU admission. Repeated doses of tocilizumab are given, and critically, we had broad immunosuppression with systemic corticosteroids like dexamethasone or methylprednisolone.
Okay, that's CRS. The second major one sounds trickier. Immune effector cell-associated neurotoxicity syndrome, or ICANS.
ICANS is definitely challenging. It's essentially a toxic encephalopathy affecting the brain. The exact mechanism isn't fully nailed down, but the leading hypothesis involves that systemic inflammation, maybe from CRS. It seems the inflammation damages the blood-brain barrier, making it leaky. This might allow cytokines and maybe even some CAR T cells to cross into the central nervous system where they don't belong, causing inflammation and neuronal dysfunction. And interestingly, the key cytokines implicated in ICANS seem to be a bit different from CRS. IL-1 and GM-CSF are thought to play a bigger role here, maybe more so than the IL-6 that drives CRS.
And you said it could be subtle initially. What are the early signs they use those neurochecks to pick up?
Yes, early detection is key. We use standardized tools like the 10-point ICE score, immune effector cell-associated encephalopathy score. It tests orientation, attention, language, handwriting. Early signs can be quite subtle. Maybe expressive aphasia, the patient has trouble finding the right words even if they know what they want to say. Or dysgraphia, their handwriting suddenly deteriorates. That handwriting test is simple but surprisingly sensitive. If it progresses, you see worsening confusion, delirium, profound sleepiness, somnolence, and in the most severe cases, seizures or even swelling in the brain, cerebral edema. Catching that transition from mild symptoms grade 1 towards more significant issues, grade 2, is crucial.
And the treatment is different from CRS, pharmacologically speaking.
Yes, this is a key distinction. For ICANS grade 2 or higher, the primary treatment is prompt initiation of corticosteroids.
Not tocilizumab.
Generally, no. Tocilizumab is considered largely ineffective for ICANS.
Why is that?
Two main reasons. First, tocilizumab is a large antibody molecule. It doesn't easily cross the blood-brain barrier to reach the site of the problem in the CNS. Second, it targets IL-6, which, as we said, might not be the main driver of ICANS compared to cytokines like IL-1 or GM-CSF. Corticosteroids, on the other hand, are potent, broad anti-inflammatories that do cross the blood-brain barrier effectively, so they are the mainstay for controlling neurotoxicity.
This really highlights that balancing act you mentioned earlier, using steroids to treat the toxicity, but potentially at the cost of reducing the CAR T-cell effectiveness.
That is the constant clinical challenge. Steroids are life-saving for severe CRS and ICANS, but they are immunosuppressive. There's always that concern. Are we controlling the fire but also dampening the anti-tumor immune response we worked so hard to generate? Clinicians have to weigh the immediate risk of severe toxicity against the potential long-term impact on efficacy. It requires careful judgment, close monitoring, and often involves difficult decisions about when and how aggressively to intervene with immunosuppression.
Okay, let's say the patient gets through that intense first month. The acute storms have passed. What are some of the longer-term issues they might face?
While recovery can take time, one common issue is prolonged cytopenias. Because of the LDC chemo, maybe the CRS itself, patients can have low counts, neutrophils, platelets, red blood cells that persist for weeks or even months after the initial recovery. This means an ongoing risk of infection, bleeding, and needing supportive care like growth factors or transfusions.
And for the CD19 targeted therapies specifically, there's that expected side effect involving normal B cells.
Exactly, it's an on-target, off-tumor effect. The CAR T cells are designed to kill anything with CD19 on its surface. That includes the cancerous B cells, but also all the healthy, normal B lymphocytes. So patients treated with CD19 SARS develop B-cell aplasia, basically, no B cells. And since B cells make antibodies, this leads to hypogammaglobulinemia, very low levels of protective antibodies in their blood. This leaves them highly vulnerable to certain types of infections, particularly bacterial ones. So many of these patients require long-term, sometimes lifelong, infusions of intravenous immunoglobulin, IVIASH, to replace those missing antibodies and provide passive immunity. Plus, they often need prophylactic antibiotics or antivirals for extended periods.
Wow. So the complexity, the toxicity, the cost.
Yeah.
It's all driving a huge amount of research into making this better, safer, more accessible. What's on the horizon? You mentioned off-the-shelf CAR T.
Right, allogeneic RRT cells. This is a major goal. Instead of using the patient's own cells, autologous, these are made from T cells collected from healthy donors. The huge advantage. They can be manufactured in large batches ahead of time, quality controlled, frozen, and stored, ready to go off the shelf when a patient needs them. This completely bypasses that whole lengthy, individualized vein-to-vein manufacturing delay and the issues with variable patient T-cell quality.
That would solve the V2VT timeline problem entirely.
It would. The challenges shift, of course. You have to worry about the patient's immune system rejecting the donor cells, graft versus host disease in reverse, or the donor cells attacking the patient, GVHD. So they often require additional genetic engineering to mitigate these risks, like knocking out the T-cell receptor, but the logistical benefit is potentially enormous.
And then there's the even more futuristic idea, skipping the lab altogether, in vivo CAR T-cell generation.
Yeah, this is really revolutionary thinking. The idea is to engineer the T cells inside the patient's body. Instead of apheresis, shipping, manufacturing, LDC infusion, you might just give the patient an infusion of, say, specialized lipid nanoparticles carrying mRNA or DNA that encodes the CRR, or maybe an engineered virus designed to specifically target and modify T cells in vivo. The patient's own body becomes the bioreactor.
That sounds like science fiction. What would be the impact if that worked?
Oh, it could be transformative. It could potentially eliminate the need for those incredibly expensive, centralized GMP manufacturing facilities. It could dramatically lower the cost. It could make CRT cell therapy accessible far beyond the specialized academic centers where it's mostly done now. It solves the V2VT timeline issue instantly, condensing weeks of manufacturing into potentially just the time it takes for the delivery vehicle to find and modify the T cells. And maybe, just maybe, engineering the cells in situ preserves their natural fitness even better. It's still early days, lots of hurdles, but it's a very exciting frontier.
And finally, even for the current autologous approach, making them safer. Engineering solutions.
Definitely. Lots of work there. Things like armored CARs, which are engineered to secrete substances like cytokines such as IL-12 directly into the tumor microenvironment. This might help them overcome resistance, especially in solid tumors. And on the safety side, a big focus is on building in safety switches or kill switches. For example, incorporating genes like inducible caspase-9, ICASP9, into the Sarakhi cells. If the patient develops severe uncontrollable toxicity like CRS or ICANS, the doctor could administer a small, otherwise inert drug that specifically activates the caspase-9 switch, triggering rapid apoptosis or programmed cell death of the SAR T cells. It gives clinicians an off button for emergencies, offering much greater control over that safety-efficacy balance. #tag outro.
Okay, let's try and wrap this up. What an incredible journey. Autologous carry-IE T-cell therapy, it's clearly transformative. For many patients with hematologic cancers, it offers hope where there was little before, even the potential for long-term remission, maybe cure. But as our deep dive showed, its success hangs entirely on executing this incredibly complex vein-to-vein pathway flawlessly. It demands just meticulous coordination, doesn't it? From patient selection, managing the washouts, the apheresis, the manufacturing, the LDC timing, and then navigating that intense post-infusion period with CRS and ICANS. It really takes a village, a highly specialized village.
It absolutely does. And that core tension we kept hitting on, that's really the defining characteristic of this field right now. The very same powerful immune activation that you need to destroy the cancer is precisely what causes the potentially life-threatening toxicities. So the ongoing challenge for everyone involved, scientists, doctors, manufacturers, is how to better master that delicate balance. How do we maximize the anti-tumor effect while keeping patients safe? Through smarter CR designs, better toxicity prediction and management, maybe those safety switches, it's all focused on tilting that balance favorably.
So thinking about that V2VT timeline, the data linking longer times to worse outcomes, and then looking at these future technologies, like in vivo generation, potentially eliminating the wait entirely. Here's something for you, our listeners, to think about. Could that logistical race against the clock, the whole V2VT challenge, actually become obsolete in the near future? Imagine if creating these cancer-killing cells moves from a specialized, centralized lab process directly into the patient's own body. What would that mean? How might it fundamentally change who gets this therapy, when they get it, and where they can receive it? It could truly reshape the landscape.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.